So as we all know, retinal ganglion cells, as we all know, retinal ganglion cells, they form the RNFL, they form the axons, that forms the RNFL, and following which they form the optic nerve, right? So in certain diseases like glaucoma, we see a degeneration of this RNFL thickness and ONH cupping, which leads to vision loss. And I'm sorry, I'm not able to view the slide in here. So it's not just glaucoma that affects the RNFL thickness and ONH cupping. It is also the non-glaucomatous diseases such as multiple sclerosis, NMOSD, Alzheimer's disease that affects the RNFL thickness and ONH parameters. So our study aim was to check the changes in RNFL thicknesses post-cataract surgery, mainly phacoemulsification, and the changes that we see with an SD OCT. So in our study, we included 60 patients, of which they were all 18 years above. And we included patients only those who were posted only for phacoemulsification with IOL, in-the-bag IOL implantation. And we excluded patients with any sort of ocular opacities and any sort of other retinal, those patients that were not willing for follow-up. So in our study, we pre-op evaluation, we did a proper thorough ophthalmic investigation. That included BCVA, IOP, fundus examination with plus 90-degree diopter post dilation, and we checked the patient also on slit lamp biomicroscope. Following which we did an SD OCT scan preoperatively after dilation as well, and we noted all the changes that is required for RNFL changes, and patients were followed up post 1 month. And the same evaluation was redone again. So in our and for the cataract grading, we used the LOX3 grading system, and in our results we found that there was a in our age distribution, we found there is a majority of in the age range of 51 to 71 years of age, and then we had a slight male predominance of 53%, and our signal strength, we noticed that there was a significant post-cataract surgery. A significant increase in our study, it shows significant increase in superior and temporal quadrants, and most of the changes were seen in posterior subcapsular cataract. And as per you can see in the graphs, the changes were also noted as per each cataract type and the quadrant wise. And we did notice that a few other studies also had similar findings, but at the same time they were also contradictory, mainly because they used a different OCT machine, and they had a different sample sets which are lower in number, around 30 to 40. And we found that there was a significant change overall, but in our study we mainly found there is a significant change in the superior and temporal quadrant. And to conclude, a significant improvement in signal strength was noticed, which improved the cataract imaging quality, and quadrant well analysis also showed a variation from other studies, which to conclude, to show that we have to re-evaluate every single patient that we suspect glaucoma before starting any glaucoma medications for such patients post-surgery. Thank you.
So just one question. You have included all the glaucoma patients in your
Yes, ma'am. We have no.
So how do you say that you have not compared the normal with the glaucoma? Have a conclusion saying that RNFL has a significance in these cases?
Yes, ma'am. So in our case, even though our exclusion criteria, we didn't have an exclusion for glaucoma per se, we had no patients which were diagnosed with glaucoma. So even with non-glaucomatic patients, prior to they were not diagnosed, even those patients, we saw a significant decrease post-surgery. There was RNFL thickness was lower, post-surgery it increased. So we should not misdiagnose patients with
No,
just
so what do you conclude? Because that initial part, it will increase. That is already seen and proved. So what does your study show, or what do you give the message to the thing?
My message is we should always do a reassessment of RNFL thickness and ONH.
Yes, you can do, but does the RNFL has a significance of treatment in anything? Because just doing anything doesn't have, because already so many things have been done, and what is the conclusion and novelty of your study?
Ma'am, in my study we found that there was a significant, even without a prior diagnosis of glaucoma, they found that there was a significant increase in the superior.
So tell me why there is a significant increase only in your superior quadrant, what you were talking about. What is that it was showing of superior?
It goes against ISNT law.
So in that case, your study design should have been different. You should have done a comparative study, and then you should have told, because you are taking a normal genera and talking about it, it doesn't have a significance. Okay, anyway, it's a good study, but to do anything, think in future about it.
Thank you.
Okay, thank you.
So was it a prospective study, Dr. Mathew?
Yes, ma'am, it is a prospective study.
Okay. So to what do you attribute the increase in RNFL thickness post-surgery?
Ma'am, mainly the clarity of signal strength, clarity of the imaging that was done pre-operatively because of the cataract. The image was not clear, signal strength was not clear. Because of that, the image we received were not of proper values. So post-surgery we got more clarity of we can see, we were able to image it more clearer.
So did you include all patients who had some complication during the surgery also, or were they excluded?
No, ma'am, they were, none of our phacoemulsifications cases were even full.
Okay, so that was not mentioned, I think.
Sorry.
Probably that should also be mentioned.
Yes.
Fine.